Published, 18 November 2010. One life ends, another begins. Management of a brain-dead pregnant mother. A systematic review *, 2010. Abstract background. An accident or a catastrophic disease may occasionally lead to brain death, BD, during pregnancy. Management of brain-dead pregnant patients needs to follow special strategies to support the mother in a way that she can deliver a viable and healthy child and, whenever possible, also be an organ donor. This review discusses the management of brain-dead mothers and gives an overview of recommendations concerning the organ-supporting therapy. Methods to obtain information on brain-dead pregnant women. We performed a systematic review of Medline, EMBASE and the Cochrane Central Register of Controlled Trials, Central. The collected data included the age of the mother, the cause of brain death, maternal medical complications, gestational age at BD, duration of extended life support, gestational age at delivery, indication of delivery, neonatal outcome, organ donation of the mothers and patient and graft outcome. Results. In our search of the literature, we found 30 cases reported between 1982 and 2010. A non-traumatic brain injury was the cause of BD in 26 of 30 mothers. The maternal mean age at the time of BD was 26.5 years. The mean gestational age at the time of BD and the mean gestational age at delivery were 22 and 29.5 weeks, respectively. 12 viable infants were born and survived the neonatal period. Conclusion. The management of a brain-dead pregnant woman requires a multidisciplinary team which should follow available standards, guidelines and recommendations both for a non-traumatic therapy of the fetus and for an organ-preserving treatment of the potential donor. Background. Brain death, BD, as coma de passe, was first defined by Mollaret and Goulon in 1959. 1. And it remains the medically and legally accepted framework for the diagnosis of death. Death is pronounced on the basis of well-defined clinical examinations followed by confirmatory technical tests. Recent improvements in life support technology and critical care management make it possible to maintain the patient's vital functions after BD. The question whether to offer life support to brain-dead patients and how long it should be provided has become a controversial ethical issue. The issue is still more complex when BD occurs during pregnancy. Of course, the incidence of BD in pregnant women is very low and there are only few case reports. As shown by Sotheby et al. 2. Of 252 brain-dead patients, only 2.8%, cases involved pregnant women between 15 and 45 years of age. When confronted with BD in a pregnant woman, physicians must primarily focus on saving the life of the fetus. And therefore the treatment protocol should give special recommendations on how to support the mother in a way that she can deliver a viable and healthy child. After delivery, brain-dead pregnant women may also be candidates for organ donation. Therefore, two aspects must be considered in case of maternal BD: supporting the fetus until successful delivery and, if possible, supporting the brain-dead mother as an organ donor. Hence, if the mother and the fetus are regarded as two distinct organisms, maintaining the vital functions of a brain-dead pregnant patient may be ethically justifiable to support both the birth of a child and possible organ donation. In such a situation, various clinical disciplines such as neurosurgery, intensive care medicine, obstetrics, neonatology, anesthesiology, transplantation surgery and an ethics committee should work together to minimize maternal and fetal morbidity as well as mortality. Since only a few reported cases are to be found in the medical literature, Most approaches to managing a brain-dead mother remain experiential and relatively little publicized. In this article, we review the available cases of prolonged somatic support in brain-dead pregnant women and analyze when and under which circumstances the pregnancy should be maintained and what challenges are to be faced. To present a protocol to support such patients, we discuss the management of the brain-dead mother and fetus, related recommendations and legal and ethical issues. Methods search strategy. We performed a systematic review of Medline, 1975–2010, EMBASE, 1982–2010, and the Cochrane Central Register of Controlled Trials, CENTRAL, the Cochrane Library Issue 1. 2010, for relevant citations. Keywords used in electronic searching included, maternal brain death, pregnancy, brain death, management of brain death, and fetal monitoring. Reference lists of retrieved relevant articles were screened for other studies. Additionally, to include all existent studies, we also contacted experts in the related fields of brain death and pregnancy. Study selection and data extraction. All studies which reported at least one case of maternal brain death during pregnancy were eligible for inclusion. We excluded studies dealing with pregnancy in a persistent vegetative state because brain death adds complexities to pregnancy that are very different from a persistent vegetative state, calling for different medical management and obstetric strategies, as well as other legal and ethical considerations. Furthermore, we excluded studies which only discussed ethical and legal issues and studies providing insufficient data. There were no language restrictions. One reviewer, M.E., screened all titles and abstracts to assess whether they were potentially eligible for inclusion and whether full text was required. Then abstracts and full texts for all potentially eligible studies were reviewed by two researchers, M.E. and Eck, who independently evaluated these articles and extracted their data. Any disagreement during study selection and the data extraction process was resolved by discussion with a third author, A.M. According to our search of the medical literature, 30 cases of maternal BD, 19 case reports and 1 case series, were reported between 1982 and 2010. The collected data included the age of the mother, the cause of BD, maternal medical complications, gestational age at BD, duration of life support and gestational age at delivery. In addition, we evaluated the indication of delivery, mode of delivery, neonatal outcome and organ donation by the mothers, as well as the transplant outcome. In our analysis, we particularly focused on the critical care management of brain-dead mothers such as respiratory and cardiovascular support, endocrinology and thermoregulation, nutritional support and organ donation, as well as aspects of obstetric management, including fetal monitoring. Statistical analysis. The statistical analysis was performed using SPSS 14.0 software for Windows, Stata Corp., College Station, Texas, USA. All statistical data regarding maternal age, duration of maternal support, gestational age and fetal birth weight were expressed as means. Figure 1 summarizes the process of literature identification and selection. According to our search, between 1982 and 2010, 19 case reports and 1 case series were published. In Table 1, we summarize the 30 reported cases of extended maternal life support after BD with pregnancy and the resulting neonatal outcomes.